Okay. Anyway, we will, but you are not able to see me. Huh? Okay.
At present, sir.
No problem. Anyway, I think we'll start with the event. No problem. Okay.
Okay, sir.
Yeah.
So, can we start, sir?
Yeah, I think you will be introducing the speakers and all, no?
Yeah.
Right.
Yeah. Yes, sir. Yes, sir. I'll welcome everyone and then hand over session to Dr. Vanmati.
Okay, and then Dr. Vanmati will hand it over to me. Okay,
Yeah.
right.
Yeah.
Okay, thank you. Maybe you can say that there is some technical problem, so Dr. Zog may not be visible. Okay.
Okay. Yeah. So, can we start, sir?
Okay. Sure.
Okay. Good evening, all. First of all, we sincerely apologize for the delay because of technical glitches, and our Dr. Pramod Jog also cannot start the video because of technical glitches. We are delighted to welcome all the pediatricians to today's Pediatrician Pathshala Scientific Convention Module 3 on Issue 3. Last year, we successfully completed Pediatrician Pathshala Module 2, where we explored 5 crucial aspects of rational use of antibiotics, respiratory tract infections. All archived sessions are available on Pediatrician Pathshala YouTube channel. This year, we have started Pediatrician Pathshala Module 3, and we have already completed 2 issues. One issue was with Dr. Bhaskar Shinoy, and second, we have successfully completed with Dr. Ashok Rai. It's our honor to have Dr. Pramod Jog as a scientific coordinator with us, and as today's speaker, Dr. Uday Pai, for issue 3. Today's session will cover exciting and clinically relevant topics and different case studies that will be of great interest for every pediatrician who is present here. Now, I would like to invite Dr. Vanmati, who is Associate Professor of Pediatrics at Savita Medical College and Hospital, Chennai, and Medical Officer at Macro Labs. She'll introduce today's eminent panelist and take the program forward. Over to you, Dr. Vanmati.
Thank you, Sureka. So, good evening, one and all present here. So, Macro Labs. It's my immense pleasure to welcome you all to the academic session, Pediatric Pathshala, Guiding Light to Excellence. This is a module 3 Pathshala website where we have uploaded all the completed videos from module 1 and 2. And these videos are also available in access that. And today's topic is issue 3. Topic is improving antibiotic prescription practices. And today's speaker is the moderator is Dr. Pramod Jog. So it is my pleasure to invite speaker Dr. Uday Pai. So he is the president Mumbai IA, and he was organizing secretary of Pedicon 2019. And he was a vice president IMA Chembur Maharashtra 2001, and he was the organizing chairman of Pedicon 2004, and he was a principal investigator ISAC since 1996, and academic affairs CIAP 2016-17, and executive. And he was a joint secretary MD IAP 2011, and he was involved in various programs, TV, digital courses, and he was a chief national communication plan of 2018 to 19. And our moderator for today is a senior pediatrician from Pune. He's a professor of pediatrics, DY Medical College, Pune, and he was a president of IAP 2016, and he is a standing committee member in 2016 to 19, and he was ex-vice president infectious disease chapter IAP, and he's a standing committee member of ASPID, Asian Society. So I hand over the session to Dr. Pramod Jog.
Sure. Thank you. So I hope I am audible, but I am not visible. Am I right, Uday?
Yeah. Yes, sir. Yes, sir.
Yeah. I think, recently we had a similar meeting, and then somebody said, you are audible, you are visible, but we hope that you are not horrible. Okay. Anyway, so we will start with today's meeting, and it's all related to the antibiotics today. And it gives me great pleasure to welcome you all for this session on improving the antibiotic prescription practices. Okay. And as all of us are aware antibiotics are among the greatest discoveries in modern medicine. Since the introduction of penicillin by Alexander Fleming in 1928, they have saved millions of lives. And the diseases that were once fatal, they became treatable. The surgeries became safer, and the child mortality dramatically declined. Of course, there is a powerful quote by Sir Alexander Fleming, who discovered penicillin, and he warned us that the thoughtless person who plays with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin resistant organism. And even decades ago, he foresaw the problem that we are facing today. Antibiotic resistance is no longer a distant global issue. It is present in our OPD, in our emergency rooms, and the wards. And we see rising resistant patterns, treatment failures, longer hospital stays, escalating costs of the healthcare, and limited second line options in children. And in pediatrics, the challenge is even more delicate. Children come with high rates of viral infections. There is a lot of parental anxiety. They expect a quick relief. And many times early in the illness, there is uncertainty about the diagnosis. And there is always a pressure on our minds to avoid the complications. Of course, we are standing on the crossroads between the clinical caution and the antimicrobial stewardship. So antibiotics, basically, I always feel, that's a shared resource, and we have to use them wisely to preserve their power for tomorrow. My dear friends, as pediatricians, we are the guardians of the most vulnerable population, and that is children. And every antibiotic prescription that we write has some consequences. Recently, one of my friends got a degree of MRCH, and I told him that in the era of infectious diseases, when we use antibiotics irrationally, you get MRCH, and that is the impact on the microbiome, the resistance to the drugs, the impact on the community, and impact on the healthcare system. So you are surprised to know this new full form of MRCH. Okay, so we should understand that today's session is not about blaming anybody or criticizing anyone about the prescribing patterns, and it is about reflecting on the evidence, strengthening the rational decisions, and reducing unnecessary exposure to the antibiotics. And we have to protect the children from resistance, adverse effects, and, as I said, microbiome disruption. My dear friends, we will be discussing different aspects related to the antibiotic therapy, and today's session will help us to reflect as to when antibiotics are truly indicated, how to communicate effectively with the parents, and the strategies to reduce unnecessary prescribing. It is very important that we listen to this program throughout to the end, and I encourage everyone to engage actively and use the chat box and share your perspectives and reflect on your own prescribing habits, because ultimately it's not about only the resistance, it is about the quality of care. And the best prescription is not always the strongest antibiotic, it is the right antibiotic at the right dose for the right duration. And I'm so glad that my friend Dr. Uday Pai is the esteemed speaker for today's session, and he will guide us through the practical strategies and the evidence-based approaches to improving the antibiotic prescription in pediatric practice. So with this short introduction, I hand over the proceedings to Dr. Uday. So it's all yours, Uday. Thank you.
Thank you, Dr. Pramod. Inspiring message. And I think, it is always good to hear a teacher, and we realize that being a professor for so long, the simple messages which go across are always the most apt messages. And we always looked at, like you said, MRCH, we know APT actually stands for antibiotic properly used, proper therapy of antibiotics. And we realize that these are simple small messages which create and importance, because in our clinical practice, whatever we see and whatever we do are actually related to whatever we put into application or whatever we have learned from the esteemed teachers. Ankit, can you share the slide deck, please?
Yes, sure.
When Dr. Jokes spoke to me and he said that we must look at trying to understand what we do, I basically said I'll restrict myself to trying to basically give a prescription-based office practice approach, which is very important to everybody. And we always realize that clinically appropriate things that we do on a daily basis will actually give us a right way. And even after two and a half, 3 decades of practice, we realize that taking time, being judicious, and like Dr. Pramod said, restricting wherever necessary or wherever unnecessary as to what are the important things that we should be doing is going to be very important. So like the topic is prescription antibiotics in pediatric office practice. And what I'm going to do here, just run through what antibiotics basically help us and how, like Pramod said, they are life-saving, they are important to what we do on a daily basis. And we realize that we have to be judicious, otherwise a time will come where resistance is going to be a problem which all of us are going to face in our future. Next slide, please. So what do you think when we are prescribing? What is the first thing which comes to mind when we are prescribing? We have to look at the simple factors, and which, in a mnemonic, Pramod always has a way of bringing out the MRSH message was such a clear message that we should understand on a daily basis. So what we basically should ideally comprise when we're looking at the phases are: 1, is an antibiotic necessary to be prescribed? Second, what should be the choice and what should be the most appropriate antibiotic? Third, whether it is a regimen with a dose, route, frequency, and how long it should be given. Very important when we look at any clinical situation which is related to an infection. And last but not the least, is it achieving the end result? That is what we should monitor, and that is what we call as monitoring the efficacy. And is this antibiotic effective in achieving the goals? Next. Ankit, next slide, please. So what is that we commonly see in our office practice on a regular basis? In our outdoor practice, the commonest things that we require an antibiotic for use amongst children are very simple. Yes, day-to-day, non-specific upper respiratory tract infections, where you probably see a sore throat, pharyngitis, pharyngotonsillitis, sinusitis, anything related to upper respiratory. And if it is allowed to be continued or look at additional problems related to upper respiratory, you probably look at an otitis media. Second, you will probably see seasonal or unseasonal waterborne or foodborne or environment-borne diarrhea. And last but not the least, this is one particular zone which says a gray zone, that is pyrexia of unknown origin, of fever without a focus. I mean, you are not able to identify what the focus is, and that is why the fever. Now, most of these times, they may be seasonal, may be viral, and may not require an antibiotic. So very clearly, there are times where antimicrobials are often unwarranted. Next slide, please. Why do we err? 90% of the times we are very confident when we say, okay, it's a viral fever. But at the same time, like our teachers always taught us, the minute you diagnose viral fever, make sure you do not prescribe an antibiotic. So what happens? It's an erroneous trust in our ability to treat all infections with fever with an antibiotic prescription. And that was probably the way, because, two decades back, we did not have adequate, let's say, diagnostic backup facilities which could probably get into it. And once we realized that, yes, it was a virus in nature, and we realized that it is self-limiting, and within 72 hours, the virus would probably stop giving any major issue and give rise to lesser problems. And last but not the least, we equated fever with antibiotic, which is why probably now you see t-shirts which are printed with saying it, when it is fever, it is not infection. Every fever is not infection. So clear messaging is what is required when we want to address and when we think there is chance for it. What is the second most important? There are a lot of parents who feel that the prescription is not completed, there is no antibiotics. So a lot of the times antibiotics are prescribed with the belief that if the primary infection is viral, there is always a secondary infection which may be bacterial. No evidence, but advocacy is an antibiotic. So this actually tells us what happens in 60 to 70% of our general practice, dental pediatric practice, and we realize that we must not succumb to this issue as far as possible. Next slide, please. So when we make the same mistakes again and again, then trying to understand what is the best cover, how broad can be the spectrum, how high generation can arrive. But we have to realize that it may not be in the best interest and also may not be safest to write the highest generation or the broadest spectrum. Second, there's a huge tendency towards injectables more often than needed. Either to pacify the parent or to take care of anxiety, or there are certain areas where it is practiced that injection is the only way the child gets better. Last but not the least, and this is a problem which is faced, the duration of use is often not regulated. And we see it more in our country because in addition to most antibiotics available in a 30 ml pack, which is not a complete course, there are a lot of times when the child gets better, the parents do not continue and buy a second pack. Third, often an upgrade or a change of antibiotic if a patient continues to have fever despite antibiotic use. Because there are a lot of fevers which actually take 3 to 5 days to settle down. So there are, once your diagnosis is sure, please don't change the antibiotic just because the fever is not coming down. One, it may be because of incomplete diagnosis or the dosage which was given of the antibiotic could have been low. Third, the route of administration, incorrect choice. Like, we always say under the diaphragm and above the diaphragm, possibilities of using the wrong choice of antibiotic and wrong family of antibiotic, phlebitis or some other reason why which is antibiotic it may have not reached. And last but not the least, the problem everybody is facing today with resulted antibiotic resistance and ineffectivity to treat the infection. Next. So bacterial resistance, lots is spoken about this, lots of debate going on, lot of discussions in this particular directive, and we realize that overuse of antibiotics, wrong use of antibiotics, wrong diagnosis, incomplete antibiotic therapy, incomplete duration of therapy, and we realize that the same antibiotic will not achieve its goals, will not achieve its impact and develop a resistance. Drug resistance is a result of exposure to a drug which may be genetic or may be acquired. Which, when it is resistant, what does it do? It doesn't influx to the site. There's a high efflux, so it doesn't achieve the MICs which are required to achieve its goals. The drug is inactivated because of the resistance, and of course, the action on the site of action, cidal or bacteriostatic, which probably we feel should be the base part, does not get it. So does it actually matter? Next slide. Yes, it matters more than we think that it actually does. There are multiple genetic formulations which we have inside the body which are responsible for either horizontal transmission of resistance to genes between species or maybe genetic engineering as well as social as well as equalitarian activity, which is very well understood, because of which today the protein structure of most of the bacteria changes and it develops a way of not responding to the antibiotic and achieving its goal. Next. So very simple, the paradigm of any proper prescription would be trying to avoid these three things, because if you continue abusing the antibiotic, you are either excessively or inappropriate use will give rise to main two things which are going to be responsible for long-term problems. Either developing a resistance, not achieving its goal as anti-infective, or failure of the antibiotic treatment and giving rise to complications which we may receive, which will probably result in more and more problems. Next slide. So choice should be very, very, very well decided and should be determined largely by one, look at the source or the focus. Like I mentioned, above the diaphragm, below the diaphragm. Try to use antibiotics above the diaphragm. Cefixime is an antibiotic which works below the diaphragm, more for GI kind of infections. Similarly, you have amoxiclavulinic acid as well as first generation cephalosporins which work above the diaphragm and achieve its goals. The age of the patient. Younger the patient, better the response to simple antibiotics. And of course, if the severity of the infection is very high, especially in preterm immunocompromised children, then you will have to look for higher antibiotics and higher generations. Most important, trying to tell again and again, if it is viral, no antibiotic. Don't think that you're trying to treat a secondary infection by adding an antibiotic. If it is bacterial, it definitely needs to be looked at whether it's community acquired or nosocomial. The reason being very clear, in community acquired probably would be something which is maybe a gram-positive in nature, whereas nosocomial may be very, very high, very, very virulent kind of organisms which may require gram-negative in nature and which may require either parenteral therapy or may require higher antibiotics. But today we are going to look at office practice, and most office practice infections are usually community. If it's a school-going child, you basically ask the child or the parent, anybody else in the class is coughing, anybody else in your friends are having a similar kind of infection, and that basically gives you a very clear idea as to what kind of infection is in circulation. Next. Now let's look at a few cases. These are simple cases which we see day in and day out in our practice, and probably a general pediatrician would probably be absolutely enlightened to see the diagnosis. Case number 1, Apurva. It is a 1 year, 6 month old male. Apurva can be a male or a female, both. But here it's a male boy. Brought with history of fever and cough with rhinorrhea for 2 days. Child has coryza, red eye, absolutely red eyes, inflammation, mild diarrhea, no rash anywhere on the body. A mild cough is present, but history of similar problems or symptoms in the family. So we start thinking. Next slide, please. What are the first things which come to our mind? Next slide, please. I continue. One look at this particular, it's a common kind of picture which you'll see. You'll see a congested throat. You'll see a few flakes of pointers where you're looking at infective spots. Next slide. So very clearly, we realize the two main things which come out of the history. One, there's somebody else in the family who is probably having the same infection. Second, any community or any particular same kind of symptoms occurring in any of the family members, 90% it will be seasonal in nature. So the first thing which comes to your mind would be a viral upper respiratory infection. If you find tonsils a little enlarged, yes, you probably call it tonsillitis. But definitely you'll see a sore throat with mild spots, and these spots are small follicles which are viral follicles. May not be very evident to give rise to huge purulent or suppurative kind of phenomenon. So very clearly, an antibiotic is not required here, but supportive line of management to take care of waiting to tide over a 32 or a 3-day period or 72-hour period for self-limitation of the virus, and looking at the spots disappearing in 72 hours would be ideal, and look at trying to give a lot of fluids, maybe a warm water or gargles or something which is very local in nature to give this. But what happened with the same child is the throat swab culture was sent and the child was started on amoxicillin 30 mg per day. per kilogram. And 2 days later, the child improved. The throat culture showed beta hemolytic streptococcus resistant to penicillin, means it has probably come to a place where child has already been exposed to some antibiotic in past. So the antibiotic was changed now because of the beta hemolytic to coamoxiclav 40 milligram per kilogram. Now what comes to mind here is, when you initially thought that it was something in the family and you realized that it was viral in nature, but it did not respond, and later on we had to do a throat swab. So what comes to mind? Is sending a throat culture and static and antibiotic justified? Second, what would we look at commenting on an antibiotic sensitivity? Next slide, please. So, sorry, go back to the previous slide. So we realize very clearly that only when infections do not come under control with antibiotics, or our clinical diagnosis is viral, but thus fever doesn't come under control, this is probably the only indication to, after 3 days of fever, to look at possibility of those particular white spots which were there. You can take a swab of that, and that particular gram stain will probably give you a little easier idea with gram staining itself. Because there are times when after taking the swab, looking at the gram stain, getting a culture, you lose another 2 or 3 days. Which is why probably this is a good way to approach a case. First, if you suspect virus, don't give an antibiotic. But if there is no response, which we actually very clearly said in our first 2 or 3 slides, take a swab, do a gram staining, do a culture, and if the culture shows that very clearly, we realize that depending on the sensitivity, we realize and we know that beta hemolytic streptococcus will respond to coamoxiclav and will give good results. So this is a simple case where, yes, if you are thinking of virus, don't prescribe, but reassess, review the case. If required, even do a gram stain, identify, and go ahead with therapy. Next slide, please. Now let's look at another case. This is a child, 4.5-year-old child, Mehul. He's brought with clinic with 2 days history of high spiking fever and mild cough. What is the first thing which comes to mind? Possibility, immediately you will look at, yes, probably the cough is something which is upper respiratory, and definitely we know high spiking fever, possibility of first thing which comes to mind depending on what season it is, and especially in this warm season, we do realize that these are a season where you will probably see a strep throat infection or a staph infection which will give rise to some kind of infection in the oral cavity, and that's identified. Next. So when history and examination is taken, the child did not have any red eyes. There was no coryza or rhinorrhea, no rash anywhere on the body, but difficulty in swallowing and very, very similar, no history of any similar case in the family. So we realize here that this is not community acquired, this is related only to the child, 4.5-year-old child, and he looks very sick even when he doesn't have fever. Next slide, please. Ankit, next slide, please. So when we look at doing an examination, what are the first things? I mean, because of the high fever, because of pyrexia itself, there's tachycardia. So heart rate is 110. The respiratory is 28 to 30. Good perfusion with the blood pressure which is normal. Right tonsil was large with a purulent discharge and the inflammation on both the sides. The cervical lymph nodes, especially the omoid or the digastric lymph nodes, both were absolutely swollen and tender. Tender cervical lymph nodes with both nose and the ear not showing any inflammation. Most of the other systems were absolutely normal. So yes, this is probably a direct case of tonsillitis, and which is probably what we will see Now, once the summers come in, this find that most of these particular strep and staph throat infections do pop up. Next slide, please. Very common. I mean, there must be a lot of times when we have seen a very similar kind of a throat when we put in a torch or put up a tongue disperser. If you see, both the tonsils are inflamed. There's a suppurative patch on the left hand side, purulent patch, and you will see that both the tonsils are coming very close to the uvula. So almost like coming closer and closer and giving rise to severe pain while swallowing. Next slide. So what was the difference between Apurva and Mehul? Very simply, Apurva started with red eyes, rhinorrhea and cough and diarrhea. No rashes from the body, congestion in the pharynx, no rash anywhere, no cervical lymphadenopathy, and younger age. With history first in the family, so we initially thought it was viral. Later on, when they didn't respond, the white spots take a swab, and then we saw that that's what we give streptococcus. In Mehul, very clearly toxic child, acute onset with severe throat pain, difficulty in swallowing, rapid progression, very little cough and cold, very bad pharynx congestion, thick exudates, follicles, purulent and patchy lesions on the tonsils with absolutely tender lymph nodes in the neck. Very toxic, age a little on the higher side, 3 years. Which is why probably first diagnosis there would definitely be bacterial suppurative tonsillitis or pharyngotonsillitis with a patchy kind of a patch on the right tonsil. Next. Okay, next slide, please. So viral versus bacterial always has predictive values. So what are the good predictive values here? I mean, if you look at viral, you look at presence of a watery nasal discharge, maybe absence of any pharyngeal erythema, absence of exudate in the tonsil or follicles, no tender lymphadenopathy, may multi-system involvement may be possible. Sometimes with virus, there's always a possibility of some rash on the body which may either come after the fever goes or when the fever is just beginning. And of course, community or family with similar problems is going to be the diarrhea. And most of these, better than the predictability, no single sign will say it's this virus. So you probably need to evaluate on what you are actually visible and what you are realizing. And the only thing which comes to your mind is younger the child, more likely to be viral. Older the child, the exposure being high, more likely to get exposed to bacterial infection in a community. Next. So, what are the things that you keep in mind when you want to look at how you manage? Very simply, we need to understand that in our office practice, if we keep simple aspects in mind, or simple clinical signs or clinical symptoms as well as history in mind, it becomes very easy because once you are able to explain to the parent what needs to be done, and you're confident in telling that, the parents today judiciously will follow you, and that will give you the best result that you need in future. Next. Very simple. If there is a reaction, if there is a non-response, if oral do not help, if the pus does not settle down, we do have to keep in mind that in children where there is no penicillin allergy, we probably need to keep in mind that even oral penicillin, which is not only no longer available but actually therapeutically very beneficial, oral amoxicillin, or there are times in our old 2.5 decades back where a single dose of benzathine penicillin would give good results. But today, none of this is necessary for our office practice. I just made a mention of this for the basic reason that there may be still areas in the interiors, maybe in rural interiors where today, antibiotics may not be compliant with the parents, and they may require a single dose where benzathine penicillin or penicillin V would probably achieve its goal. Next. But in oral medication, very simple, we realize that those who may be very, very prone to allergy and where we think that even oral penicillin derivatives like amoxicillin would be something which we cannot give because possibility of either rash, reaction, anaphylaxis or diarrhea, then you probably need to look at other choices where macrolides play a huge role. So erythromycin, ethyl succinate, 40 to 50 milligrams 3 times a day, or azithromycin oral 5 days, 12 milligrams per kilogram once a day. And first generation cephalosporin, which I mentioned, cephalexin, cefadroxil, 25 to 30 milligrams per kilogram have achieved its goal. Only where you think that the failure of macrolides may give a necessity, the second line probably is clindamycin, which can be oral 10-day therapy of 10 to 20 milligrams per kilogram. Next slide. What happened with Mehul is also something very interesting. The child was treated, child was followed up, but at the end of the day, 4 months later, Mehul is back with the same fever, same cough and coryza. And now look at his throat. The throat, the particular patch and purulent tonsillitis which was there disappeared today. There's some little discharge on the retropharynx, and now the pediatrician thinks that okay, this doesn't seem to be the purulent which I saw 4 months back, though he's come back with the same symptoms. It now looks like pharyngeal pharyngitis. Do you think so? Next slide. The pharyngeal erythema is always most likely to be viral and less of bacterial if there are no purulent follicles or pustules which may be seen there. Next. Now let's look at trying to understand differential diagnosis. We have all seen such throat. If you actually look at, the throat on the left hand side, multiple white spots, multiple follicles, but there is no coryza. If you see, the nose is clear. Child did not have very high fever, but these are non-bacterial pharyngeal inflammation. On the right, which we see very often now, probably we'll start seeing it in the next 2 months, there are these particular ulcerative kind of lesions with erythema all around and a small puckering in the center, may have little amount of whitish color discharge, may not have a discharge. These are differential diagnoses which we need to keep in mind whenever we see non-bacterial pharyngeal inflammation. So what are the things that come to your mind when you go on the left hand side? The common things which come to your mind. Next slide. Etiology for similar kind of things. If it is viral in nature, it can be any rhinovirus, especially enterovirus, which influenza kind of thing, or para-influenza viruses, adenoviruses, cytomegalo, coxsackie, herpes simplex, Epstein-Barr, and bird flu. And in addition to all this, the newer things that we see now may be related to either infectious mononucleosis or even your hand, foot, mouth disease will show similar kind of spots inside the oral cavity, and that also is something which probably we must keep in mind. But if it is bacterial nature, yes, very clear, like we did a swab in the first child Apurva, and we identified beta hemolytic streptococci, which probably is very common, 15 to 30% in children around 3 years or plus, and lower in those children which are, it's more in children beyond 3 years and less in children who are less than 3 years. Very rare, but also to keep in mind, we may have not seen it. I mean, the last case of probably a Corynebacterium diphtheria I must have seen when I was doing my MBBS at the Sion Hospital, and those were the times. But yes, we must keep H. influenzae as well as Neisseria germs with Gonococcus and Mycoplasma as also a possibility to these particular illnesses. Next slide. Third case. Now this is an Azhar is a 15-month-old, otherwise healthy boy, who only came with nasal rhinorrhea, mild cough, fever of 102 for 2 days. But on day 3, he became fussy and woke up crying multiple times at night. So the first thing which comes to our mind, what could be wrong? How does one child evaluate? It actually tries to remind us that yes, whenever a child comes with infection which is more than a couple of days, always try to understand that this possibility of upper respiratory giving rise to multiple complications, and we need to look a little beyond the throat, and you start thinking of examining the ear. Next. Ankit, next slide please. So on examination, yes, commonest, you touch the ear, you move the ear a little and the child is crying a lot, or the child is actually putting a hand on the ear, or third, in the middle of the night, suddenly the child gets up crying a lot. So we realize that on examination, the possibility is look at the erythema of the tympanic membrane, probably notice some bulging of fluid beyond the membrane. The mobility of the tympanic membrane becomes a little tough, and of course, it suddenly comes without any rhyme or reason after 2 days. You have to start thinking of a middle ear infection giving rise to pain and severity of the illness. Next slide, please. So, Azhar had acute otitis media, especially in the right ear. Next slide. Very clearly, we all realize that the management of otitis media, especially in a very small child, first requires paracetamol in adequate doses. Sometimes we realize that paracetamol may not achieve its goal in reducing the pain. Paracetamol should be 15 milligrams per kilogram. You may look at trying to give plain ibuprofen, never a combination. Try to stay with a single and not a fixed drug combination. And you can give anywhere between 7.5 to 10 milligrams of ibuprofen for pain. Antibiotics in divisive doses. The first choice of antibiotic is always co-amoxiclavulanic acid. Second choice would probably be a cefaclor, which has shown good results. And third choice can be clarithromycin, all of which have definitely shown good results. There are no rules. Please be very careful. There is no role for any decongestants, and of course, absolutely no role for ear drops. The parents will continuously ask you, "Nani, kaun sa drop done?" There is no role for any ear drops. Next slide, please. So we realize in our day-to-day practice that if we are very judicious in taking a good history and trying to understand how to evaluate whatever the parents are giving us a history, and be very clear and patient that unless the fever doesn't come into control, we don't need to get into a situation of trying to address all that comes to us with an antibiotic. Ever since the last 8 or 10 years, Central IIP and all the presidents of Central IIP have run multiple programs. The first program that I run was rational antibiotic practice, and we realized the importance of bringing this to every pediatrician. After that, we had the program on avoiding antibiotic abuse. Then we had something called as apt pediatric antibiotic therapy, AAPP. After that, we started realizing severe infection requiring high antibiotics and judicious use. Then we had antimicrobial stewardship programs where we realized that hospitals which run a proper program will use antibiotics judiciously in all the places common, so that there is no cross resistance and avoiding the effectivity of antibiotics. I'm quite sure if we realize over a period of time, and now we also understand that if we are judicious in nature, the amount of antibiotic usage will definitely be appropriate and only when necessary. Thank you very much for a patient hearing. I'm quite sure Dr. Pramod Jog will have good messages to send across. And if there are any questions in the chat box, Dr. Vanmati will be glad to take it.
Sure. Thank you, Dr. Uday, for that insightful and thought-provoking presentation. And I'm sure we have learned that most of the childhood viral infections obviously do not need antibiotics, and clear communication will reduce the parental anxiety, and the overuse of today will limit the options tomorrow. So we have to be very, very careful. And in pediatrics, basically, our responsibility is even greater, because when we discuss about the microbiome, even a single use of an antibiotic will lead to dysbiosis, and these are the children, even at a later date, can develop hyperactive airways and some of these complications related to dysbiosis. Okay. And I always feel that just because we have a pen to prescribe an antibiotic does not mean that we should prescribe an antibiotic. Okay. Actually, today's session has highlighted quite a few practical take-home messages, and Uday, you will be happy to know that I have tried to fit them in your own name. Okay. So your name is Uday. I have changed that last Y to I for the sake of convenience. So I have said U stands for use evidence-based guidelines. Okay. D stands for differentiate viral from bacterial. Okay. A stands for avoid unnecessary broad spectrum antibiotics. And I stands for instruct the parents and educate them confidently. Of course, we have to commit to asking ourselves one simple question in our daily practice: whether this antibiotic is truly necessary for this child. And that comes with your surname Pai. So I will say PAI stands for pause and introspect. Pause and introspect. Okay. So if one simply uses this measure, that you pause, I have seen this child, he has sneeze and wheeze, so he really doesn't require antibiotic. He has watery nose and watery diarrhea. Yes, he really doesn't need antibiotic. Okay. So as you rightly said, almost 90% of these infections are viral in nature. See, you told the microbiology of the respiratory tract, and if everyone understands, tonsillopharyngitis, in 70% cases it is viral, except for sinusitis and otitis media, where we have basically 70% bacterial versus 30% viral. The throat infections, which we call as tonsillopharyngitis, all are related to those viruses that you told. Okay. However, one should be aware of the microbiology so that he knows when to use and when not to use. So Dr. Uday Pai has given the messages, and I have tried to fit them in his own name. Okay. So the most important thing is that you have to have that commitment on your part about use. Not that you should not use antibiotics, but you should use them like a steward. Steward is the person who protects the antibiotics, because we have limited stock, and the future of antibiotics depends on the decisions that we make today. That's very important. So I thank all for being a part of this important conversation. And Dr. Uday, again, congratulations for that excellent presentation. And Dr. Vanmati, I hand it over to you. In case if there are any questions, please feel free to put them to the panel. Thank you.
Thank you, Dr. Pramod. I think I'm going to remember that PAI, pause and introspect. It's absolutely appropriate. Absolutely appropriate. Thank you. Thank you for creating that on the spot.
Thank you.
Thank you, sir. So as we conclude today's Pediatric Pathshala Scientific Convention Module 3, resistance, we extend your heartfelt gratitude to our esteemed speaker, Dr. Uday Pai, for his insightful and impactful session. We also moderator, scientific coordinator, and the visionary behind Pediatric Pathshala, the joyful Dr. Pramod Jog, who's master and skillfully providing the session as always. A gentle reminder to download your participation certificate from the Pediatric Pathshala platform. with just one click. We look forward seeing you again on the rational use of antibiotics. So featuring another exciting topic to enrich your pediatric practice next month. So thank you once again. Have a wonderful
Thank you.
day, sir. Thank you, Pramod, sir.
Bye.